So this is a 43 years old male, known case of hypertension, diabetes, tobacco chewer, smoker, presented with evolved anterior wall ST elevation MI with moderate airway dysfunction. And this is a yellow caudal view, and you can see he's a chronic diabetic with uncontrolled diabetes, and you can see how small the LAD and diagonal is. And there is a thrombotic lesion in the proximal LAD to mid, and you can see how small the distal LAD is and this diagonal also. And this is a areocaudal view, and you can see there is a tight lesion in the proximal LAD is almost about 90%, and normal LCX OM, and the diagonal also there's a lesion right from the ostium. In this cranial view, epicranial view, you can see the distal LAD is so small vessel. This is the problem in diabetic patient. They have very small and vessels, so it is very difficult to put a stent in such a patient, and graft also. So you can see almost this proximal LAD is almost of size of this catheter. Catheter is around 2. This is the areocranial view, and you can see the point of bifurcation where the D1 is coming out. You can see the tight lesion is there. So with right radial root, we engage the left main with the catheter XB 3.5 into 6 French, and this is BMW PTCA wire. We went ahead with this angioplasty to this LAD, and you can see the diagonal also. There is a lesion in the diagonal right from the ostium. So the difficult is the stent size, because we have minimal 2.25 size. So this proximal LAD has size at around 2.25, and distal is less than that in mid also. So we decided to take a 2.25 stent into 28. So this was the placement of the stent. The stent is 2.25 into 28. Wanted to cover that tight test portion. We wanted to put a stent right from the ostium. So just one strut we kept in the bifurcation point, and in this scene you can see one strut we just kept in the bifurcation point. So nailing the ostium technique. Then we inflated the stent at around 10 atmospheric pressure. 8 was the nominal, and this was the picture. We were not happy because there was an under expansion, and you can clearly see there's an under expansion at the tightest portion. So we decided to do the NC. So we did the serial NC. This was the tightest portion. We inflated the balloon there, NC balloon, at around 14 atmospheric pressure, and this was towards the ostium. And this is the picture after the NC. There's always been the problem in the acute MI. There will be a slow flow after doing NC, after doing stent. So we have given tarifiban and everything. So this is a cranial view, and you can see the flow has improved. So we put this patient on the infusion tarifiban, and we left this diagonal because it was a very small vessel. And this was the iliocaudal view, and you can see the flow has improved, and now we are happy that there was no under expansion. But you can see the size of LAD compared to the LCX. LAD is very thin size, and this happens in the diabetic cases. And distal, if you see the vessel in the LAD is very small, very thin vessels. So this is a angioplasty to this evolved anterior wall ST elevation MI, and this is the areocaudal view, and you can see the well expanded stent in this segment of proximal LAD. So stent sizing in the diabetic vessels has always been a problem because of the severe endothelial dysfunction and proliferation of the smooth muscles in the artery. So it's always difficult in uncontrolled diabetic patient, long-standing diabetic patient to put a stent or even in that case the graft. So this was the angioplasty to this small LED in this diabetic patient.